Good morning. Thank you for coming. Again, I'm Amy Zellers. I've been with Diamond Healthcare for a couple years, but in the last 4 weeks, I've been the clinical nurse educator here on campus. So I'm excited to be here. I'm normally in your chair. I don't know if anyone recognizes me. So when they're like, "We want you to speak," I was okay. So it's a different side of the fence for me, being up here instead of watching as you all are. So anyway, I just want to give you a little bit of my background. Obviously, I'm a registered nurse. I've had 20-some years experience in the nursing field, pretty much any nook and cranny you can imagine. Drug and alcohol treatment, as well as psychiatric, behavioral health background as well. I also most recently working for a program that we have for Diamond Healthcare called Treatment in Place, and I was actually in the nursing homes themselves and educating the staff there about managing behaviors of the elderly population, aging population that they treat. So first-hand experience of understanding the challenges and that they also face as well. So any of you here particularly work directly with any of the geriatric population? Okay, all right, great. So anyway, moving on. Anyway, so again, we're going to talk about these challenges, which you probably know many to begin with. But so again, the big picture of the problem, not just here in our world, but across the U.S., there is a growing geriatric population. So we have our baby boomers, right? And we have more and more, and they're saying by projected to reach 98 million by 2060, right? You think we already have trouble finding placement, so this is not going to go away anytime soon. And of those, they're expected to double to about 15 million that have a mental illness or behavioral health issue. So, also, there's an increasing number of, obviously with a larger population, we're going to have the diagnoses of Alzheimer's, dementia, and Parkinson's, those neuropsychiatric disorders. So, and they're not easy to always manage or diagnose in the first place, if you're familiar. And also, a big problem, not a big problem, it sounds a terrible way to word it, but they're living longer, right? We, 18 years or more. And so our life expectancy is increasing. Provider barriers. So it's hard to find someone that can treat them, right? So I don't know, has anyone experienced that? Someone that has recognizing that someone has a behavioral health issue, and who do you send them to, right? I know that a lot of primary care doctors can't even find someone to refer them to in the first place. So again, there's a shortage of providers. Currently, 552,000 mental health professionals across the U.S. That's not very much, right? And that's of these 4 categories. And there's a limited number of healthcare professionals with psychiatric especially, just even to treat, and again, this is across the entire U.S. And it's actually a escalating crisis. So as we're identifying more mental health issues, I think it's more to our frontal lobe now to recognize we may be missing the core reason these behaviors are occurring. Now who do we send them to? Because what I'm finding from my research is there's a gap. There's more starting to take the schooling and become psychiatrists, psychologists, and neurologists, but there's also an aging population that they're retiring. So that's why right now we're in this big crisis. As I encourage my children, they're in college, I'm like, go into psychiatry. It's you're always gonna have a job there in that area, but. So, also provider barriers. So we have our primary care physicians that are seeing their geriatric population, and a lot of them aren't educated enough to really or feel comfortable enough making these diagnoses. Now, I don't want you to leave here and say, Amy Zeller said that you primary care physicians don't know what you're doing. Okay, guys, I'm not saying that. I'm not saying that you have no education, but there's many that I've worked with, spoken to as well, that don't feel very comfortable really getting into these diagnoses, especially they get masked a lot too, so they're not always extremely evident, and they're afraid of maybe prescribing the wrong medications and making things worse. Also, provider barriers. We have these aging population, they are comorbidity, if I can talk today. You would think I've never spoken in front of people before. Comorbidity, right? Do you know what that is? It's more than one diagnosis. There's usually a laundry list by the time people are 80, 85 years old, right? And multiple medications. So, and again, a lot of these behavioral health issues aren't clearly evident right away, or it takes a lot of time to really get to know that patient to really find out what's going on with them, what behaviors they're developing, and how they're presenting with it. And also, those physical chronic conditions are going to take precedence over those emotional issues, right? If you have someone that's immobile or they're in extreme pain, it's hard to diagnose if they have schizophrenia or they're bipolar or major depressive disorder. Placement barriers, as we already said, we have this increasing population of these individuals. But also, those many state hospitals have closed. Have you experienced that as well, or is that in this area? I'm originally from northeastern Ohio, and I know that was a huge issue several years ago when I was there. So, so they're downsizing the geriatric beds in state mental hospitals, and communities aren't well equipped to handle these people. So where do they end up? What's that? Yeah, assisted living or on the streets, right? Because they don't have a lot of support. They don't have any place to go. And again, patient barriers. They lack that social support. There's many, especially aging females or elderly females are single. Their husbands have passed, and they lack support or family support or anyone around them. Also, inadequate insurance. We always have to talk about that, right? And the cost of this is expensive. And there's also, as you have the stigmas and ageisms that they're working against as well. Do you like that guy? Right? I thought that made me laugh too. So, and patient barriers. So I have worked with several of the geriatric population, and remember, back in their generation, mental health meant you were crazy. They think of one flew over the cuckoo's nest. They're in a white straitjacket. I'm not crazy. That's not me. They're taught to white knuckle it. Or depression, you just don't have enough faith in God. You need to pull yourself out of this, right? So they put it on themselves. Or how many times does someone, say an elderly man, 80, 85 years old, say, I'm kind of depressed today? They usually don't present. That would be nice. It'd be like, oh, this is easy, right? So I'm not sad, I'm fine. And depression is not a normal part of aging. It's one of the most underdiagnosed mental health issues that these people face. And I understand there is ebb and flow. You're losing some of your family members. Your health is, spiraling down. You've lost control of a lot of those things. You're not able to get up and walk around like we used to. We're not as fit or feel good. We have pain every day, chronic pain and issues. So you're going to have times, or you're losing your family members, your friends, they're passing. So you're going to have sadness, but it should be an ebb and flow. If you see this sadness develop and lasting for 2 weeks or longer, those start to be red flags that we need to dive in a little further to see what's happening with them. Know thy patient, right? I always say, from everything that you can think of, what they did for a living, where they grew up, who, and even if you can, and it's not always easy to get that history, right? A lot of times they're poor historians, or they get things confused, or maybe that didn't happen to me. They're not going to be always forthcoming with all the information that we may need. So any previous psychiatric history since birth, if at all possible. I know that's not always easy. Any family history as well. Any previous suicide attempts, even if they were 17 years old, is very significant, especially in this population. It's the second highest suicidal rate of the aging population, as second to the early or teenage years. So it happens. I've taken care of people. I had an 84-year-old woman. She lived at home by herself, and she ended up in our unit. She had taken a shotgun, and I don't know how she did this, but she turned it towards her chest, pulled the trigger, and luckily missed all her vital organs, and ended up just with a perforated lung. They brought her into ER, put a chest tube in her. Once that healed, she came to our unit. And, you know, she seemed pretty well mentally intact, and I mean, she was sad, but I said, what happened? Why did this occur? And she said, I had it. My husband passed away a year prior. She had chronic pain. She had chronic migraines and been to every doctor, and they couldn't figure out what the problem was, right? She was alone, isolated, and she said, and it was an impulse. She said, you know, I just had it, and she cried. She said, I know now I can't believe I did that. Like, why did I do that? I would never do that again. I'm so sorry that I did that. And she just wanted to get back to her little dog. Animals can be the best motivators, right? You can understand, I'm a dog lover myself, but yeah, so it was kind of an impulse thing. So don't underestimate what they may do. So, also too, trauma history. Between about 75 to 80% of those that have behavioral health issues have some form of trauma, one way or the other. And this is to me, this is a short list. We know the detailed list of trauma history, right? Could be catastrophes, you know, any of those in the military that have dealt with those types of situations as well. Okay, and so what can we do? Not only get that great history, right, as best as we can, and you might even need to get, obviously by signing your release and doing all the legal things we need to do, maybe a neighbor, a friend. You might not be able to find that great family social support, but anyone else that might know some information about them. Changes in appearance or dress. See, you know, Susie used to get dressed up and try and put on her makeup every day, and she's not really looking so good. She's not keeping herself as kept as she used to. So again, there's subtle changes. So sometimes it's not going to be this blatant, blazing out to you like, oh, something's majorly wrong here. We need to catch this early on. So again, you know, prevention is the key, right? They're a little more confused than normal. Changes in weight, changes in appetite. Are they gaining weight? Are they losing weight? Sleep loss, deprivation. You know, we think, oh, they're not sleeping well because they're having a lot of pain, which could be the case, but then I always say, let's dissect that down a little bit further. Is there something else we may be missing? And then if they speak of any thoughts, you know, that worthlessness, inappropriate guilt, you know, as we age, and I think this is kind of a normal part of aging as well, where we look back at our lives, right? When we start to look at our own mortality, like coulda, shoulda, woulda, right? We're human beings. We think, I wish I would have done this differently. I wasn't there for my kids as much as I thought I should have been. You know, we have this guilt, but if it's extreme and they feel like I'm worthless and I don't deserve to live anymore, if you're sensing that or they verbalize any type of suicidal ideation or made some sort of plan of how they would harm themselves, that's a major red flag, and we need to make sure that we're looking into that.
So how is that different from normal signs of aging?
Say what?
You have listed there, you know, I'm not young. I have friends who are in their 80s.
Right.
It's normal.
It's vague, isn't it? That's why our jobs are hard. I know. I wish if I had that answer, I'd have my own island, and I'd invite you all. I know, right? It's you're.
Suicide, pathological versus normal causation.
And again, you get to ask some good open-ended questions to see how serious they are. If they, you know, if they have that ideation, if they've had previous attempts, if they also. So I always think that ups the ante. You look at that person holistically. Well, if they start saying things like this, you know what? I have a lot of regrets in my life.
But they also could have serious medical issues that have no hope. So when is it appropriate for an older person to, in fact, have suicide ideation?
When is it appropriate? Well, hopefully never. But yeah. Oh, she's asking. Oh, sure. Okay. let me make sure I have correct what when is it appropriate that they're having suicidal ideations? Is that what you're asking? Say it again.
I'm asking, actually, in this day and age, isn't that inappropriate to have suicide?
Oh, in this day and age, is it that inappropriate?
When you have doctors trying to keep you alive at all costs, and you have illness that is got no hope of getting you better.
Right, right.
So
So you're saying it could be normal to have those thoughts of not wanting to be on this earth anymore. Okay. So my response to that would be that you may have fleeting thoughts, but we need to also see fleeting thoughts of, I don't want to be here anymore, I'm sad, I'm depressed. But how severe is it? So again, if you're asking those good open-ended questions and diving in further, no? All right, let's talk.
We have a different belief system about aging and the right to choose if you can live with what you've got.
Right, right. I understand that. That's a whole nother, that'll be maybe next, no. That'll be, that's a controversy there. And no, I understand what you're saying. Okay, yeah, we can talk even more about that afterwards. So it's getting deep. Now I'm like, oh Lord, okay. Anyway, no, I appreciate the comments. That's okay. All right. Also, some of the, this, and again, it is vague, some of this stuff. Memory loss. Guess what? You're going to have that too. But again, if they're preoccupation with certain things, that paranoia, have you had that experience, which is so difficult to deal with, when they're paranoid against their own family? Oh, she's stealing money from me. They're coming over, they're stealing all my things. And how do we know, though? Sometimes maybe they are. That's hard, right? It's not an easy population to treat. You think, oh, they always get paranoid when maybe they had conflict with a sister or brother, another sibling, and so they think we think that's the reason that they act this way or they're behaving the way they are, but you never know, so never assume, right? Oh, and this is one, the physical problems, preoccupation with their health, psychosomatic symptoms. That's another one, tough. But the day, and I was a former ER nurse, the day that they say, oh, I have chest pain, and they've already had blood work, chest x-ray, EKGs, week after week, the day that we blow it off and discount it may be the day that it's actually something happening. So don't assume it's otherwise. So, and again, social withdrawing, and again, the symptoms of dementia, and again, it can be very masked, whether it's depression or dementia, that, trouble handling finances, they get their electric shut off because they thought they wrote the bill, or they drive somewhere and they end up in another county or something like that. So, and again, another very important thing we can do is developing those relationships with family. Don't underestimate what they have, or kind of even understanding the family dynamics of how they interacted with each other, their relationships with one another, and educating those families about the symptoms to look for. Have them be your eyes and ears. That's when I was educating our the CNAs and nurses at the nursing homes. You have more face-to-face time with anyone else in this facility, physicians, administrators, everyone else. We depend on your input and what you see every day. Even if it's slight changes, we need to know that. I always tell them, don't underestimate the value of what you're seeing, and don't be afraid to report it. So, and then we're going to have, Alicia's going to speak next too, and what we call is the behavioral, the psychiatric advanced directives, the POAs, before all this spirals down, before these behaviors become aggressive, violent, if they're a threat to themselves or someone else. And I think in me coming here newer to Virginia, I did not know this existed. So I think this is some great information that Alicia has to share with us. In Ohio, our advanced directives cover that, but it's different here in the state of Virginia. So do you guys have any other questions in the meantime? Now we have a nice topic for another month for our A Will to Live. So, no, all right. Go ahead.
I have a question. I just want to address something that she said.
Uh-huh.
In terms of some of these thoughts that people have when they're getting older, some of it really is just, reconciliation. Everybody does that. They're thinking about their life. It's not suicidal to think, I wish I had done something different, or I want to find a way to harm myself because my life sucks, or my kids don't talk to me, or my husband left, or this. That's something very different. So when we were talking on the screen, it indicated if you have depression that's lasting longer than 2 weeks, that's different than feeling sad today or sad tomorrow. If it's extending past 2 weeks, 3 weeks, there truly is something else medical going on, and we should be talking to our doctor. But this idea of my doctor trying to keep me alive, we deal with that with having a plan. Right. Do I have a pulse? Does my doctor know? Does my family know? What are my wishes? And then no one's trying to extend your life beyond what you want. Right. It's really having a plan and making sure people know what that is. Yeah.
And that's a nice leeway into exactly what Alicia has to share with you as well. So, all right, thank you.
Good morning, everybody. How's everybody doing?
Good.
Okay, my name is Alicia Miller. I'm a registered nurse, and I'm the nurse liaison for the Pavilion, our geriatric unit specifically. I know some people might wonder, well, what does a nurse liaison do in business development for a psychiatric facility? Well, my focus is going to be mostly on our assisted livings, independent living facilities, skilled nursing, that kind of thing. A memory care unit is a big one. And a little bit of people living at home but being taken care of by their families. So my job is when we do have someone in a facility, memory care unit for example, and they're having behavioral issues or depression issues, things that are not their norm, that are becoming concerning for the facility. I get a phone call from the facility, and I can go out and do an assessment as an RN to see if they meet criteria and try to make that transition into a psychiatric facility a little easier, because that's a traumatic thing anyway for anyone at any age to come into a psychiatric facility. So we're going to talk a little bit about that and the importance of power of attorneys, advanced directives. Some people are familiar with them. I'm sure everybody has heard of that at some point. And in Virginia, the importance of a psychiatric power of attorney, because they're not always the same. So for an advanced directive, I'm sure everyone has seen this. This is pretty much the verbiage that goes on to a advanced directive, a medical advanced directive. To authorize my admission to or discharge, including transfer to another facility from any hospital, hospice, nursing home, assisted living facility, or other medical care facility. I underline any there, so what does that mean? Anywhere you go, correct? Including the Pavilion, because we're a hospital. Not in Virginia. This is medical. So a medical power of attorney is not the same as psychiatric. In Virginia, psychiatric mental health is different than medical. So it's very important. You're probably wondering, well, why does this matter? Because if you have certain wishes about what you want to do, as far as end of life, that kind of stuff, that's all there in writing. But to have a psychiatric power of attorney or advanced directive, you're authorizing someone to get you mental health help evaluated, admitted against your will, like even if you object. Because sometimes when you're sick, you don't get to make those decisions. When you lack the capacity to make an informed decision, that's when someone needs to step in and be able to make those decisions for you. So, a myth, a medical power of attorney and medical advanced directive is sufficient for the named decision maker, your agent, to admit someone to behavioral health. That is not true. Again, it goes for any kind of medical facility, most medical facilities, unless on most power of attorneys, you can always pick and choose what facilities you want, what kind of medical care that you want. So a behavioral health advanced directive, there's verbiage on it, that's different. Some people, most people, that have a power of attorney or advanced directive, they don't have this part incorporated in it. Some of it they do, and it can, when you have them drawn up, usually people see lawyers, you have to have them signed by a doctor. So the verbiage in there will determine whether we can take someone as a patient voluntarily. You can also add a supplement for mental health care conditions, which if you already have your advanced directive and it's all medical, you can have it added, a supplement added to it that says your agent can have you admitted to a psychiatric facility. So here is an example of some of the verbiage that they include. To authorize my admission to a healthcare facility for the treatment of mental illness as permitted by law, even if I object. There are obviously different levels and what you want and what you know that you can add to this, and that's when you consult your lawyer to do these. They're more as far as the legal terms and that kind of thing, but this is one that we see. This is what we look for when we have someone coming from a nursing home or assisted living facility or home. This is the kind of verbiage that we look for someone else trying to put them into the facility, because again, when you put someone in a facility like this, you're taking their rights away. So we need to make sure that this is what they wanted. So to consent to my admission or transfer to a mental health care facility when it is recommended by my healthcare providers, and to authorize my discharge from any such facility. Obviously, there's a lot of variation and a lot of different terms you can use depending on what you authorize this agent to do. This is important because what happens if you don't give someone, your agent, the power to admit you into a psychiatric facility? Well, the only way you're going to enter a hospital is either involuntary commitment process, or for someone, an agent, to be able to have you committed or admitted to the hospital. So what happens is the involuntary commitment process. It's a petition's going to be filed with the court. You have to be taken into custody and evaluated in a hospital temporarily, and then the court hearing to, if you're detained, the court hearing to see if you're going to be involuntarily committed to the hospital. So it's kind of a traumatic process. Is anybody here, I know we have some CSB people, I think, familiar with the TDO, ECO process, so everybody knows it's kind of a traumatic thing anyway? Okay, so again, this is important. I'm speaking more to the facilities. I can use an example. We had a lady from a facility displaying combative behaviors, not normal, just getting new, starting to get where she's a danger to other patients, she's a danger to herself, and they want her stabilized. So obviously, being a behavioral health unit, we don't deal with dementia per se, but we deal with the behaviors that come with dementia. And most facilities that have these residents, they want them back. They're not trying to dump them on us and get rid of them. Especially with Pavilion, we're a privately owned, so we're not, our insurance, we take bigger insurance companies, that kind of thing. So most of these facilities want their residents back. They're paying good money to be there, they want them back. So they just want to get them stabilized to where they're safe and they can handle them. I know a lot of facilities will memory care, we can, behavior units, that kind of thing, but there's different levels that they can accommodate. Not every facility can accommodate every level, every, behavior out there. So that, they sometimes need to bring them back down to their baseline, and baselines do change, they deteriorate, that's what happens with dementia. But they want them back to the baseline to where they're safe and manageable in their facility. So we get calls to say, hey, can you come over and look at this person? Miss Jones is having behavioral issues. She threw a walker at Miss Smith yesterday and hit her in the head, and it's a big mess. So we go in, and yes, this is something that meets criteria for us as far as it's a danger to someone, we want to get her stabilized. They do have doctors, obviously, in the facilities, usually PAs and nurse practitioners, but they're not mental health normally. So they're not comfortable prescribing antipsychotics or depression meds or anxiety meds to geriatric patients because, like Amy said, all the other co-occurring issues that go on, the medications, the interactions, black box warnings, they're just not familiar with it. They don't have a whole lot of experience, and that can be kind of nerve-wracking when you're a physician prescribing things and the interactions, especially with mental health stuff and with older people. So we want to get them here because we do have a board-certified geriatric psychiatrist. We have a geriatric unit, so we cater to this population. We want to get them stabilized and get them back to either the community, their home, or the facility that they came from. So it's very important to do that. Now the problem comes in is when we say, oh, okay, great, we can get them in, let's get them admitted. Do they have a power of attorney? They do. But it goes back to the first one, where it just says any facility, and people assume that includes mental health. It doesn't. It needs to include something like this that says specifically for mental health. So it's sort of a catch-22 because we know they need the help and we want to get them admitted. Daughter has power of attorney. Well, daughter doesn't have the right to assign her into a psychiatric facility. You're taking their rights away. So even though this person does not have the capacity to sign in voluntarily, she can't have anyone else sign her in either. So what happens? Well, in this particular case, I was talking about this lady who I had a call and went over and assessed. She was evicted. I talked to the executive director of the facility. She didn't want to get rid of the resident. She's like, I've had her for a year. I love her. I want to keep her. But they're not equipped to deal with those behaviors. It's unsafe for the other residents, unsafe for the staff, unsafe for her. We can't take them because no one can get them here. They can't sign themselves in. So that power of attorney, if they would have had that mental health piece in there, whoever the agent was could have had them signed in and said, okay, let's get her in. We try to stabilize them. They're here for a couple weeks, maybe 3 weeks, and we get them back to the facility. And most facilities hold the beds. They have policies on that, however they do that. But we keep them for a couple weeks, get them stabilized as best we can, and we do understand there are new baselines, this kind of thing, but they do go back to their facilities. But without that, we're kind of stuck. And then where do they go? To another facility, hopefully. But then other facilities will say, oh, well, they're having this behavioral problems and we can't take that. So then where do they go? Oh, well, you're gonna have to go home with daughter. I got kids at home and I'm already taking care of them and I have a job. How am I gonna take care of mom? So then we run into where we talked a little bit about the TDO process and that kind of thing. That's where we get involved with legal stuff, ECOs and TDOs. Is everybody familiar with that? Is there anybody who have any questions about that? So an ECO is an emergency custody order. It's ordered by a magistrate. Any responsible person can take this out on someone if they feel that they're a danger to themselves, to others, or can not take care of themselves. The magistrate has to issue it, they have to agree to it, and then they are taken into custody, generally sent to a hospital, an emergency room, where they're usually evaluated medically to be medically cleared. And then that's when the CSB comes in and they have to be evaluated for a temporary detainment order. So when that happens and they're medically cleared, the temporary detainment order, that's also issued by the magistrate. The CSB will talk to them and decide whether they meet criteria to be detained. And if so, they go to the magistrate and the temporary detainment order is issued. Some of the things that the magistrate will consider is recommendations, obviously by the CSB worker or other people involved, past actions of the person. If they found, Miss Jones walking down the street naked, that might be a reason to commit someone. Past mental health history. And not everybody, when you think of dementia and stuff, and I think a lot of families don't even think about the mental health part because mom doesn't have schizophrenia. Mom's not bipolar. Mom, doesn't have these issues. Well, dementia is a mental illness in a way, and we deal with those behaviors, and that's what we're trying to stabilize. Not saying, well, mom is crazy because she's schizophrenic, and we understand that, but those behaviors are what we want to stabilize. So but they do look at past mental health treatment as well. Obviously relevant hearsay, just things that have happened, reports of whatever happened. So they'd like to look at any medical records, affidavits, any information that's relevant that the magistrate will want to see before they issue the TDO. Because again, that's involuntary, you're taking someone's rights away, and that's very traumatic. Like here, my picture of little grandma there in handcuffs. And they do that. It's when someone is put under a TDO, they are put in handcuffs and they are brought by a police car and brought here to the facility. So they may be in Richmond or they may be in Chesapeake, and 85-year-old, Eleanor has to be brought here in handcuffs, and that's a scary, scary thing. So we want to try to avoid that at all possible. That's our goal here. So it's a big community. It's education for the community, for social workers, for physicians, and is there anybody here that works at an assisted living facility or anything? No? Okay. So when I go to the facilities, I try to push that. When people come in, especially in the independent living and assisted living side, before they go to memory care, because I'm sure most places have a policy on, okay, do you have a DNR? Do you have an advanced directive? Do you have this? Do you have that? And kind of policy to inform them of the mental health part of it and the psychiatric advanced directive, and explain to them why. Yes, we know mom doesn't have schizophrenia. However, she's in the early stages of dementia, this, that. And while she still has the capacity to sign those papers, because it does have to be signed by a doctor and that kind of thing, that yes, when she signed this, she was of sound mind, that sort of thing, the legal side of it, which obviously consult your lawyers. I'm not giving legal advice. But we get that done, And it's easier that when the time comes, if the time comes, that you get into those situations where a facility can't handle them because of behaviors, it's an easier transition to get them to us, that we can help stabilize them. Because it is very traumatic, and it's a catch-22, unfortunately. And the knowledge isn't there. Most places don't realize that any medical facility or any hospital or whatever the verbiage is does not include psychiatric. It's very specific in Virginia.
How late is too late for someone to say, I revoke this?
If they try to revoke it, they do have to be evaluated by a physician, and the physician has to say that they have the capacity to make informed decisions. All of that, you can get on the Virginia Advanced Directives website, and there's all the information about how to do the advanced directives and what they look like and that kind of thing. But once you sign that, it's like any other power of attorney, that if you say, I want to do this and change your mind, but mental health is one of those, because you have to have the capacity to be able to make informed decisions. And it does still work like any other advanced directive. Your advanced directive only kicks in when you're unable to make those decisions. So your end of life advanced directive only kicks in when you're unconscious and you're not able to make your own decisions. So someone who is maybe going through a psychotic episode, not necessarily dementia, they can have capacity. Again, someone's going through a psychotic episode, they come to us and they are admitted, and we stabilize them, and they're back on their meds. That advanced directive turns off. So no one can make those decisions as long as you're capable. Now, obviously, a doctor has to say that, and when you're being discharged from a facility, that's generally they're saying you're capable of making those decisions again. So it's important for people, even if you have a younger person who has a long-standing history of mental illness, this might be something that you want to consider with your family, because once the legal side gets in and the TDOs are involved and the court's involved, that's the court that's making those decisions for you. Now, obviously, if you do something that's dangerous and you're detained on a street, that kind of thing, that kind of overtakes anything voluntarily. But you still have, if you're starting to have issues and they notice, hey, the meds aren't right, or you're becoming manic, that kind of thing, you can have someone put you somewhere voluntarily, so you still have some say, and the family has decisions to make rather than the courts making those decisions, because it can be very traumatic, especially with our geriatric population, and that's kind of what we're pushing. It makes those admissions to us so much easier, and a lot of times they have trouble detaining people in a facility. So even though we can't take them because they don't have the psychiatric power of attorney and they can't come voluntarily, where's their next option? It's that detainment process. But that doesn't always happen, because again, they're in a facility where they're supposed to be taken care of. They have dementia. It's not they're not walking the streets and have schizophrenia, and it's a dementia diagnosis, and they're in a facility there to treat them. So they're not really detainable at that point. That gets more with the CSB and how they get to the ER and that kind of thing in the situation. But it's more difficult when they have dementia to detain someone and get them into a stabilization facility like we are. So there's a lot of information on this website. I do encourage everyone, especially if you work with geriatrics, I know a lot of you do, but physicians' offices, families are the big one, because they're the ones that have to do this. So facilities, if you know people that work in facilities, you work in facilities, I highly encourage that you make this part of your admission process, or encourage them to talk about power of attorneys, advanced directives, and just add that mental health piece in there. And obviously, talk to lawyers, and there's different, you can cross out certain sections you want and add certain things, and you can write in exactly what you want. But highly encourage people to do this, families, before it gets to the point where they can't make those decisions, because then you get into people being deemed incompetent and become guardians, and it's a whole other legal process. So it's a good idea to have it. It helps a lot with any kind of admission process. And it takes away a lot of the trauma from being admitted to a psychiatric facility. So, yes, ma'am.
Has the psychiatric POA always been there, or has there been a law passed recently?
So,
this is now required?
It is. So my history is, I've been a nurse since 2012. I did a lot of home health administrative stuff and then went into psych. And I was a floor nurse, charge nurse for Riverside Behavioral for 4 years on their intensive unit. That's a little different facility than we are here. So we didn't deal, when you get in like a hospital system, we didn't see a lot of this. Every now and then we would with people trying to come involuntary that didn't have capacity, that families try to get them in. But in a privately owned place, I see it more because we have people coming in from facilities. So I didn't see it a whole lot with Riverside. We were mostly TDOs, or we were able to take them voluntarily, and then if they wanted to leave, we can detain them on that end because they don't have the capacity to try to discharge themselves. So I hadn't seen a whole lot of this until probably about 3 years ago, and I had heard it, but I've only been with the Pavilion for about a year. So that coming in as my job being to go into these facilities and try to get those admissions, that's when it became more relevant, more prominent. So it's been around for, I know, at least about 3 years. I'm not sure as far as the law in Virginia, but I became very aware of it when we realized, well, we set all of this up and now we can't take them because no one can put them in the hospital.
So in your experience with the assisted living facilities, are they, I'm sure you're encouraging them.
Yes.
Is that happening? As far as you know.
Kind of, some of it is. Like I say, it's relatively, I've been with them, less than a year, so getting out there and trying to give that information it's a lot. There's a lot of nursing homes, a lot of assisted livings, but it is, this information a lot of people don't know. I've had people say, I've never heard this before, ever. But most of them don't have a whole lot of experience with mental health facilities. They're in nursing homes. It's not common that you would have someone from an assisted living come to a psychiatric facility to be stabilized. It doesn't happen every day. So if they don't see it, they don't know about it. When I started doing this, I thought, well, God, people should probably know about about this. How do they not know about this? And I mean, I've even had some lawyers where we've done different conferences and that kind of things where like, I didn't even know this. They don't do family law, but they're like, I've never even heard of this. And a lot of people haven't. It's kind of, because mental health I think is still so taboo and people don't talk about it a whole lot, that they don't, unless there's those significant problems and mental health diagnosis, they're not thinking, oh, well, if I get dementia, I could be put in a psych ward. They don't think that. They're like, well, that's not me. I mean, I've done things where we're advertising for the Pavilion and people walk by and say, oh, well, what do you do? And it's for this task force, Peninsula Task Force on Aging. And they said, well, what do you do? And I said, oh, we're the Pavilion, we're inpatient psych. And then, oh, well, I'm not crazy. And they leave. And I'm like, well, no one said you're crazy. Other people do. Psychiatric issues do come up with geriatrics, not just because you're crazy. Even depression stuff, that kind of stuff like Amy talked about. But those people still have the ability to sign in on their own and that kind of thing. It's just when you lose that ability, the capacity to make an informed decision, that's when this comes in. And it's important. So you get, your wishes are kind of followed as much as you can. And we try to avoid that, getting the legal process involved. Any other? Yes, ma'am.
This is a little, it's not, I don't know if it's office or not. I was wondering what the protocol is for, you send someone to the hospital from your facility for medical reasons. And they don't have insurance and all that's the really cool. What is the protocol about how long you hold a bed for someone?
In an assisted living facility? That I cannot answer. It probably varies from facility to facility, depending on whatever their protocol is for that. If we send someone from here, like if someone's on our unit and we send them to the hospital and they're admitted, they're generally discharged from our facility. So if someone is here under a TDO and they're involuntarily committed and then we send them out to the hospital and they're admitted to the hospital, they're discharged from us and then we have to restart that whole TDO process over again if they still meet criteria.
So if they're there for 4 or 5 days, they have to come back because if they've never been here kind of thing and start all over?
Well, as far as we go, I can't speak to any, if they're in an assisted living facility and they go to the, most people, they come right back, they hold those beds. But as far as we go, when someone's discharged here medically, they're discharged from the facility and we have to go through that whole process again, which is another reason these power of attorneys are important, because just because, say mom came here and all of a sudden had a fall and they want to keep her, in the hospital a couple days, had a concussion or broke a rib, something happened. Well, now guess what? She's been discharged from our facility. So now we got to start all over.
You can't get that bed held by paying for that bed.
No. No, ma'am, not here. Yes.
So when you talked about going out to these facilities and assessment,
Yes.
are you also going to like the admissions offices and talking to them about this? Because it seems to me like it would be kind of a great thing to make part of your admissions package, as you're talking to folks at the front end about this mental health advanced directive. That way, if it ever becomes needed,
Yeah. I know our admissions, we do talk to them a little bit about it, especially with our geros that come in. Oh, at the facilities? Yes, yeah, we do talk to them, and I try to every time I go out, because generally when I go out, I talk to their sales, marketing people, their nursing director, executive directors, and admissions people. So that kind of, we try to do that. We are going to try to start doing like an educational piece where we go to these facilities and inform them on it. But stuff like this is good because we get so many people in on it, and so many people don't know about it, so it's good. Oh. Go ahead. Go ahead.
I guess I'm a little bit hung up on the handcuffing
Uh-huh.
with elderly.
What was the question?
She said she's held up about the handcuffing the elderly.
So, is that a liability issue? Because you know how elderly have really thin skin, and do the handcuffs have to go on as even if they're calm, agreeable, and will sit in the car?
I can't speak to the whole legal side of it. I'm not a police officer, but I've seen enough of it that, it's generally yes. That's anybody who goes in the back of a police car that's being transported or handcuffed. That's general protocol for the police department. I've had a couple police officers that have just had someone in the back of the car not handcuffed because either they knew them, they had a good rapport with them, that kind of thing. But generally that was when they were just bringing them in as a voluntary admission, or they were just bringing them to the hospital to be evaluated. But more than times than not, yes, they're going to be handcuffed.
And that's a law that's in it?
I'm not a police officer, so I don't know whatever their protocol is, but yes, whatever police generally follow their protocol for their station or facility or wherever they work for, with jurisdiction, that all TDOs are to be transported, and anyone being transported by a law enforcement officer is generally handcuffed. Yeah.
That needs to get addressed at some point.
Yeah, and that's going to be anybody's, whatever law enforcement agency is transporting, because we have them from all over. It can be sheriff's department, it can be state police or local police. It's just different entities, and it's whatever their process is. But, yeah. Yes. So let me let her first.
I just was wondering, is there any movement for licensure about this? I've licensed lots of programs, and I've never heard of this.
As far as having a power advanced directive, I don't think it's anything with.
They talk about that in licensure, but only the medical piece.
Right.
So I just, you don't have.
No, not as far as licensing goes. I don't know anything. I can't speak to that. I just know on the admission side of it, and that it'll give you the codes if you go on to the advanceddirective.org, it'll give you the Virginia codes as far as what it says about mental health and that kind of thing. But when you admit somebody into a psychiatric hospital, you're basically taking their rights away. So they're saying, yeah. So it's either you can't just, put mom in there because and obviously there's steps in place that you have to do. You can't just put someone in because you're the agent on the advanced directive. So I don't think it has anything with licensing. It's just it's a Virginia law thing. Yeah. Yes, ma'am. Is somebody? Yes.
I wanted to comment on the transportation with handcuffs.
Uh-huh.
I'm a pre-admission screener. Actually,
I think they're on an email list, or maybe
utilize
lay people,
medical
community
transport.
Correct.
They're not handcuffed. But the law does say anybody from 3 to whatever age, if they're being transported by the police, are handcuffed for the protection of the person being transported and the person that's transporting.
Correct. So yeah, with law enforcement, they generally are. But she is correct. When the magistrate determined that the person thank you, needs the TDO, when they go ahead and give the TDO, they can they have to put the mode of transportation on there. There's a big section in the code as far as how the patient will be transported. So if that is an issue, again, I don't work on the legal side of it, but if there is an issue and you tell the magistrate this person is 85 years old or in a wheelchair, this, that, they can probably come with a different mode of transportation to get them wherever they need to go, and that may not involve handcuffs. Just from my experience in dealing with the TDOs, generally they come by law enforcement, and 9 times out of 10, yes, they'll be handcuffed. So, anything else? Yes, ma'am. Oh, yes, ma'am.
Are attorneys being educated in this as far as when they create advanced directives?
That I cannot speak to either. I'm not an attorney. I don't work for a law firm. However, you'd think people in family law are aware of this. I would hope that they are, and I would hope that when you get advanced directives and that kind of thing, that they are informing people about this part of it. I asked a couple questions. I have a friend who's a judge and asked a couple questions about this, and obviously she knew it. She used to do commitment hearings. But family law, that kind of stuff, those would be the lawyers that mostly know about it. You get someone in criminal law, they might not have any idea about any of this. But I would hope that, yes, they are informing their clients about this mental health piece of it, especially because we are here in Virginia. So, but when people have them written up at, in different states and that kind of thing, I don't know, because different states have different laws as far as if it's inclusive or not. So I'm not sure. Yes, ma'am.
Back to this bed issue. I want to make sure I'm following. If you have Sue that is, if you have Sue who has this cough and you decide, well, she's not going to get out for 2 days, and you take her to the hospital and find out, okay, yes, we can be here a week before we find out. While she's in the hospital for a week, you're saying that she's been discharged from your facility.
From this facility, yes.
While she's in the hospital.
Yes.
So, let's say at the end of the week, they said they're ready to discharge her. Do you all go back before she leaves the hospital to restart everything? Or she has to come in just as a person to come off the street?
It's a new admission, technically. Now, if someone's admitted for observation, then we don't have to do all that. We can take them straight back to the floor. But if they're admitted as a patient to the hospital, because you can't be a patient at 2 places at once. You're either a patient here, or you're a patient at Riverside, or you're a patient at Centera. So if you're there for observation, we can bring you back. It's usually 24 hours. So if you're gone more than 24 hours, that's usually an admission, and we have to redo the admission process over again. So if you're there for observation, but if it's admission, it's a whole process over again. And that's what, if they're under a TDO, that's where it gets difficult too, because then they have to be re-detained and all of that all over again. Yes, ma'am. Anything else? Yes, ma'am.
Sometimes we have a lot of patients who are mental. They still allocate them in different homes.
I'm sorry.
I say sometimes we have patients who are in homes, like
at home, you're right.
Put them there. Are they coming from you, or they just like, some of them are discharged like from Eastern State Hospital?
Correct. And they're
so
out
they
to
look
the
for
community.
where to put them. So they get maybe somebody who can accept them and they take care of them. Are you aware of those ones?
Of the people at home, like that are released into the community, people, yes. Generally, when people have had involvement in state facilities, or even facilities like this where they've been there multiple times and they're released back into their homes in the community, generally they already have someone involved with them. The CSB is involved, they have a caseworker. A lot of times they have a guardian. Right, so, correct. And so if they have a guardian, then none of this really applies. If there's a guardian in place, then the guardian gets to make those decisions. They've been deemed incompetent. They have someone that makes those decisions. So this is more geared towards the facility kind of patients, because they're the ones that are trying to get in to get stabilized and get back to those facilities. and people in state hospitals, that kind of thing, that's more where they've had a significant mental illness and they have a history of that. Most people in facilities, they don't. They're usually dementia, Alzheimer's things, so that's where it gets tricky because most people don't think you'd ever need a mental health facility or behavioral health facility because mom's getting dementia. That a lot of people don't correlate those together. And even though they're coming here, they're not really coming here for the dementia, they're coming here for the behaviors to stabilize those. So that's kind of what this is more geared towards. Like I said, those with a long history generally have there's someone in place that's dealing with their issues if they're involved with state hospitals and that kind of thing. Yep. Anyone else? Well, thank you very much. We are going to have Dr. Gibson. We'll get you guys out for a break, about 10, 15 minutes, and then Dr. Gibson should be coming to talk to y'all and answer any questions about the admission criteria for us. She might be able to answer some questions better for you about as far as why we do the observation and coming back, that kind of thing. She might be able to answer a little bit better, other than hospital policy kind of thing. But so you guys go ahead and take a break. Thank you guys so much for listening, and Dr. Gibson will be here 10, 15 minutes, okay? Thank you. Okay, so we have one more presenter with us, Dr. Norris Gibson. She is our geriatric psychiatrist here on our Magnolia unit, and she's going to speak to you all a little bit about our patients and a little bit about our admission criteria, and she'll be happy to answer any questions for you. And this is Dr. Gibson.
All right. Good morning, everybody. So the direction I'm gonna go in is gonna be a little bit different because as I was pondering about some of the challenges that we face with treating the geriatric population, I realized that it's extremely broad, it's challenging in itself and numerous. So what I wanted to do instead is to actually discuss a case of a patient that I've had an opportunity to treat, and we can all discuss and identify some of the various barriers that this particular patient has had, as I believe that some of the challenges that he's faced are very common to those that we have in the community. So I had the opportunity to work with a 59-year-old gentleman who was admitted because he was dealing with depression. He had to stop working as a plumber, and he had been retired for about 16 years. As a result of retiring, he really hadn't done anything with his life, wasn't productive anymore, and part of the reason why he ended up retiring is due to the fact that he was no longer as functional as he had been in the past. He ended up having osteoarthritis and a lot of chronic pain. So that led to him no longer being able to work, as well as having depression. Over that same period of time, as it had been 16 years since he last worked, he suffered with depression significantly, and his alcohol intake increased from just 12 ounces of beer a day to a 6-pack a day to a pint of whiskey every day. In addition to this, just because of his functional impairments, he had chronically been having thoughts about wanting to die. Only once did he have a plan, but he had never acted on that plan. And at the current time that I was treating him, he had an intent but no specific plan in place. In addition to having depression, anxiety, and osteoarthritis, he also had a history of seizure disorder. So with all that said, he already is in a bad situation to begin with. Because he's not able to work, his finances are limited. So he received disability. It was less than $1,000 per month. He lost the home that he was living in. So he was receiving services through a ministry in Northern Virginia. I'm not aware whether he had any transportation, and he had difficulty with being able to get his medications filled on time. At the time that I had met with him, he had been out of his antidepressant for about 3 days. His alcohol intake continued the same, and he felt that he needed the alcohol because he actually felt that alcohol was the best treatment for him in terms of alleviating his depressive and suicidal thoughts. He felt that whenever he stopped his alcohol intake, he began to feel worse about himself, and he had even increased thoughts to kill himself. He realized that while he felt that alcohol was helpful, it was also a problem, so he wanted to get help for that. So in a nutshell, that's the scenario of a patient that I worked with. Now, just based off of some things that I've mentioned, and any of you can answer, what are some of the issues or barriers that you can identify just right from that scenario? Y'all can just yell anything. Income, lack of support. What else?
Housing issues.
Housing. Did someone say insurance?
Medication.
Okay.
Antidepressants and alcohol, I'm not sure that's a great mixture.
Absolutely, you're correct. Absolutely. Okay, so we've identified a lot of things. Lack of income, the combination of alcohol and antidepressants, and really even alcohol itself, the lack of support, lack of finances, everything. So let's kind of talk about that. One thing that I actually didn't hear in this case was the fact that his own mental illness itself was a barrier. So the guy that I worked with was 59 years old. However, we know that in the older adult population, and especially the geriatric population, we know that in terms of depression, the suicide rate is at the top, especially 65 years old and older. They are at increased rate of completing suicide. And that's followed by an age bracket of, I believe it's 45 to 54, followed by 55 to 64. So the fact that we know that their suicide rates are increasingly elevated, that lets us know already that we have an unmet need. We have this population that we know needs help, but for whatever reason, we're not able to clearly, we're not really able to meet their needs the way that we need to, because clearly this is a crisis at this point, dealing with depression and dealing with suicide in itself. Now, my patient was able to receive the help that he needed for two reasons. One, he expressed that in addition to being depressed, he was suicidal, and he also wanted help with his alcoholism. But outside of being depressed and suicidal and being suicidal, did you all hear me mention any other symptoms suggestive of a depressive disorder? Say that again.
Losing his purpose, retiring, not being able to work.
Yeah.
So
So a lot of the things that you mentioned, those are symptoms of depression, but not a major depressive disorder, which most people can readily identify. The things that you mentioned are typically associated with despondency and hopelessness. So most people can readily recognize major depression in terms of, for instance, you're looking at their appetite, their energy levels, their concentration, whether they're able to sleep, if they're suicidal. I mean, you have this whole list and you say, okay, if you have these 5 symptoms for over 2 weeks, we can definitely work with you. But the problem is, like my patient, if he had not mentioned alcohol use and being suicidal, it's very likely that he wouldn't have received immediate help. Why? Because all he said is, I'm depressed. And why was he depressed? Based off of his psychosocial circumstances, to be quite honest. So some people are not able to get the help that they need, and especially not right away, because sometimes it's not recognized. Other times it's considered as, okay, well, this is how you feel, you'll be able to get out of it. And sometimes we're just not really as sensitive to the warning signs that we need to be paying attention to if, in fact, they're not expressing any thoughts of wanting to die or hurt themselves or hurt somebody else. In addition to sometimes depression not being recognized, how many people with mental illness do you know who's actually going to ask for help? Not everybody. He was a special case where a lot of times you have people who are homeless as he was, and in place of being able to have, in order to have a safe place to stay, a lot of times they will seek hospitalization or they will seek help. They know that they need it, but they know that there's another gain or benefit by being in the hospital. You have other people who continue to believe the stigma associated with mental illness. the fact that it's considered a weakness or you're crazy. I really don't want anyone to know about it. And unfortunately, it's associated with a lot of shame. So you have some people who are not reaching out for help. Like my patient, he actually didn't have any type of support system. He said that he didn't have any family in Virginia. There may have been family out of the state, but he wasn't in communication with them for reasons that he chose not to disclose. He was a workaholic in the past, so for him, that was his life. He had never had any serious relationships, never had been married, didn't have any children. So he truly was a loner, and without his job, he actually suffered with increasing depression because he didn't feel like he had any purpose, like you mentioned before. So he definitely had his lack of support. Now, the other thing is, I mentioned to you earlier that I didn't know whether he actually had transportation or not, but if he did have transportation, what medical condition did I mention that would provide a barrier in him being able to readily get around? Absolutely, seizure disorder. Because we know that anyone who's had an active seizure, you can't drive for at least 6 months until you've been checked out by your primary care doctor or neurologist, and then you're able to drive again. So he had actually had a seizure, I think the day prior to being admitted because he had run out of his medications. And although he had run out of his medications, what we find that's common to the community is that people will readily go and get drugs and alcohol as opposed to getting medications. Why? Well, many times, as he mentioned, he felt that alcohol was the best thing for him because why? It numbed him. So it took his mind off of his external circumstances. He wasn't sitting here worried and anxious. He wasn't feeling like he was depressed, although we know that with alcohol, it actually is a depressant, and a lot of times you have to keep more and more to kind of get that numbing feeling away, or to keep that numbing feeling. But it was something that, although he recognized as a problem, he continued to desire. So the alcohol for him was able to give him some type of immediate benefit. Now, since I'm dealing with this particular patient and his main issue was depression, we know that when it comes to treatment for depression, there is no miracle pill, meaning you don't take a pill today and you feel great within minutes. Alcohol and other drugs a lot of times gives you an immediate satisfaction that you don't get with a lot of our drugs. So most people want that immediate gratitude, immediate alleviation, so that I can feel good right now and I'll just deal with the consequences later. And so in addition to our medications not having an immediate effect, of course, we know that there's barriers in terms of just trying to get to mental health facilities. If we were to make a comparison between whether it's inpatient hospitalizations or outpatient clinics, how many mental health facilities do we have in comparison to, let's just say, ABC stores or even grocery stores where you can readily get what you need and you're done? And then, of course, we know if you're on the street, it's easy to get drugs on the low for cheap. You get what you need and you keep it moving. It's difficult to be able to get the drugs that these patients actually need. And then, as mentioned before, a lot of times they're mixing it with controlled substances and alcohol. And of course, you're pretty much you're not going to get any benefit from the actual drugs that we're trying to utilize to help these people get better. Now, with my patient, although he had taken antidepressants, he was willing to continue taking them. One of the barriers even in that is the fact that as a provider, I couldn't do anything to fix his physical condition, which was for him one of the biggest causes of his depression, is the fact that he now had osteoarthritis. As a result of that, he dealt with chronic pain, and he's no longer functional. He's no longer mobile, agile, independent. So how do we deal with that? That's a barrier in itself where medications don't fix your external circumstances. Now, we know that in many times when we're dealing with people with depression, for instance, we always talk about the fact that antidepressants in combination with some form of psychotherapy, whether it's interpersonal or CBT or anything like that, the combination of those two give you the best benefits. But who has the resources, the money, the time, the support to be able to get to these resources, such as therapy, in addition to being able to get medication management. It becomes an issue. So we have all of these challenges and barriers that we can readily identify, because it's very common, not just for my patient, but for many people in the community. And I think that if we take a chance to actually focus on the things that are right in front of us, we'll hopefully be able to make a greater impact for the population of people that we serve. For instance, right here in this room, we're a community of mental health advocates and providers. So what can we do on this level? What are we able to do on a local level? How can things that we do locally affect our government, affect our state, and how can those things then prompt a national change in our mental health? Sometimes we get limited and blocked because we don't always have the funds and the resources that we need to be able to supply and provide the care and all the things that we know would be helpful to our community. And it causes us to have to kind of get creative and crafty with how we can be of assistance until we can get more resources and more help from the government and from the state, et cetera. So anyway, while this particular case that I brought up is dealing with a patient who had depression, the reason why I brought him up again was just because in his case, you can identify so many barriers that you probably hear from people that you are around or that you work with all the time. And again, if we can find a way to be able to alleviate some of these challenges, then we will be able to do a greater good for a lot of the patients that we treat and that we serve. Are there any concerns, any questions that you might have for me? Oh, no.
Like, we get tons of questions.
All right. All right, well, thank you all.